A Challenge to Dignity. Our goal was to link academics, activists, and agencies concerned with the health of refugees and asylum seekers in a spirit of collaboration and comparison, bringing together professionals working with different populations of forcibly displaced peoples, ethnic groups, and nations. The video you are watching will contain all the presentations in one of 5 thematic sessions. We hope you find them to be of value. Our next paper is jointly authored by Olga Odgers, who is a sociologist whose principal research interests are in the crossroads of migration, religion, and health, focusing on the experience of migrants trapped in mobility on the US-Mexico border. She is a professor at El Colegio de la Frontera Norte in Tijuana. And Olga Olivas Hernandez, who is an anthropologist with research expertise on new spiritualities, mental health, and migration, as well as substance abuse and healing systems. She is also in the social studies department at El Colegio de la Frontera Norte, and she is also a lecturer in the global health program here at UC San Diego. The title of the talk is The Use of Waiting as a Deterrent to Migration and Its Effect on the Well-Being of Asylum Seekers. Olga?
Thank you. Thank you so much for this introduction and for organizing this amazing event. I start saying that this is part of a larger project that we are working on collaboration with our colleagues at UCSD as well. And I will read to not be lost on time. So the US-Mexico border has traditionally been a transit migration zone, but significant changes have occurred in the last 5 years. The diversification of the places of origin, a more substantial presence of women, minors, and accompanied minors. Likewise, the reinforcement of border control has led to a diversification of crossing strategies, adding to the flows of undocumented crossing, asylum seeking, or protection under the temporary protected status. In addition, and this is important but not very visible, there has been an increase in the number of waiting places and times. The pandemic has been a critical alibi to increase even more the stranding times. The conditions of strandedness is produced by, among other causes, the tightening of border controls, frequent changes in the laws and procedures governing asylum requests, and growing efforts by the Mexican government to take it harder for potential asylum seekers to travel through Mexico, in concert with a growing global tendency toward externalization of borders. Thus, migration strandedness is now a central aspect of the mechanisms for controlling migration in transit, both in the Americas and other contexts. For this reason, we considered it necessary to understand the implications of the lengthening of strandedness from the migrants' experience. This study is part of an ethnographic research project, Itinerario sobre Salud y Migración, undertaken in 2019 in Tijuana, Baja California, Mexico. We primarily conducted fieldwork in one shelter for migrant families, which also functions as a cultural center. Its residents include children, youth, adults, and to a lesser degree, the elderly. They have a capacity for 25 persons approximately and provide different services to the migrant community living in and out of the shelter. We have followed up on their situations at the border for periods that range from weeks to 2 years. We conducted an ethnographic observation at the shelter while developing a knitting workshop, attending cultural events, and teaching Spanish lessons. Based on our contact with the migrant community living in the shelter or receiving its services, we conducted 47 in-depth interviews in Spanish, English, and French. The participants in the study were primarily from Central America, the Caribbean, and Africa. Most of the participants were stranded in the border region either because they were waiting to start an asylum petition in the United States or were under the MPP. The rest were redefining their migration project, beginning a refuge petition in Mexico, finding possibilities to get temporary or permanent residency, looking from family reunification in Mexico, or waiting to cross the border undocumented. The condition of the migration project was not static in some cases, and individuals or families could move from a stranded condition to a redefinition of the project or vice versa. From a structural or systemic perspective, we can consider that the condition of strandedness is produced by the combined effect of different national states' migration policies, which configure what Michael Lagier calls transnational management of undesirables. In essence, undesirable populations are pressured to leave certain territories and arrive to other countries where effective mechanisms to implement their reception are inexistent. It produces spaces of strandedness, which become visible with the appearance of refugee camps or overcrowded detention centers for immigrants. We argue that the increase in waiting times is not an unintended effect of the current migration policies. It is a control and deterrence strategy over migration. Therefore, migrants are stranded within their mobility rather than in waiting, which means that official and extra-official devices force them to remain for uncertain and extended periods in places they did not choose. There are some hotspots for migration strandedness in Mexico, which include its northern and southern borders. Both places of strandedness are part of what Campos called the Mexican transit control regime. We consider that understanding the devices that produce strandedness is essential, but it's not enough. In addition to analyzing the structural dimension that immobilizes population within their migration trajectories, it is necessary to add a phenomenological analysis that understands the experience of strandedness from asylum seekers and migrants' perspective. From our perspective, the condition of strandedness relates to the migration project. People are stranded when they cannot move forward to their destination places, neither backward to their home countries. Elsewhere, we propose that it is possible to identify at least 4 different types of strandedness based on the identification of the migration projects: truncated projects, deportees that cannot return to the host countries, neither have another place to go; in waiting projects, asylum seekers in Mexico or the United States under the MPP, or migrants that are unable to start an asylum petition due to border closures and restrictions; shifting projects in the face of the impossibility to continue the migration project. An alternative project is shaped during migration grief. Parallel projects, new migratory projects emerge under strandedness, and the former project also remains. Economic and emotional resources are invested to reach both, even knowing that they are exclusive. We would like also to talk about how strandedness occurs. In the specific case of the Mexican transit control regime, the most evident migration strandedness device is this in the South is operated by the Mexican Commission for Refugee Aid, forcing then tens of thousands of refugee claimants to face an uncertain wait in precarious conditions. On the northern border, where we mainly conducted this study, the main strandedness devices are those related to deportation, return, and removal, Title 42, as well as the provisions that affect those who attempt to apply for asylum in the US and must remain in Mexico before doing so. Some of the recent instruments that have lengthening waiting times are the closing of the border under the health contingency and the MPP. Others, less obvious, are related to the difficulty accessing the information on new legislation and the mechanisms to request asylum, or the obligation to have a lawyer given the lack of resources and the fact that civil society organization lawyers working pro bono are overstretched. Some implications of strandedness we argue that strandedness means that people stranded within their mobility must remain for extended periods in stranding societies, not host societies. And these societies lack integration strategies and consider them persons in transit. Additionally, migrants struggle to concentrate their efforts and resources on the integration. But more profoundly, strandedness produces a tension between putting life on waiting for months or years and life that continues flowing or drawing on despite everything. Thus, for example, children stop going to school but continue growing. Migrants and asylum seekers remain in shelters or precarious houses because they are temporary, but time moves on for months or years without a worthy place to live. A chronic health problem has not been cared for because they have not arrived at the destination place to receive quality health care, hopefully. Nevertheless, the health problem continues to get worse. These tensions affect migrants' well-being, who from precariousness must develop strategies to cope with it. Matthews and Izquierdo propose that well-being is an optimal state of an individual, community, society, and the world as a whole. It is conceived of, expressed, and experienced in different ways by different individuals and within the cultural context of different societies. We're interested in approaching a perspective that addresses the individual, community, and social dimensions of well-being experiences in particular contexts and temporalities. To this end, it is necessary to understand the circumstances faced by migrants in places of strandedness and the meaning that time acquires in the course of these experiences, especially considering the uncertainty and indeterminacy they go through during the administrative procedures related to their migration processes. To approach the relationship between places of strandedness and well-being experiences, we considered it relevant to understand the social meaning that these places have, not only as a context in which well-being as an outcome emerges, but as places that are inherently relational in both its production and its influence. Places understood as relational requires attention to the processes that help to build a sense of community, social cohesion, and trust, enhance livability, and so forth, an approach that has come to be labeled as placemaking and place shaping. The processes of placemaking and shaping have implications for well-being and can be identified through the opportunities and constraints migrants and asylum seekers experience while pursuing integration in places of strandedness. The following are some of the conditions experienced during strandedness that impact migrants and asylum seekers' well-being. First, mobility has implied the abandonment of life projects anchored in the place of origin. Although preserving one's life becomes a priority during mobility, people who migrate hope to achieve stability in the present and be extended into the future. However, the uncertainty of strandedness prevents stability from being accomplished. There are various losses, material and social, associated with the departure from the place of origin. Still, there is difficulty accessing resources, material, social, and political during the migration experience, allowing them to visualize viable life projects for the future. Under these circumstances, these populations may face a constant redefinition of their migration and life projects to find stability in the present from where they can project themselves into the future. We will share short vignettes from the story of some of our collaborators in this study. Together with her parents and sister, Karen fled violence in El Salvador. During her migration trajectory, she went through various emotional experiences and a suicide attempt. Derrick wrote both from the precariousness in which she found herself in Mexico and the abandonment of a life project that excited her and gave meaning to her life in her place of origin. The family redefined their migration project several times, started their refugee application in Mexico, and later abandoned it after experiencing violence in the country. Subsequently, they began applying for asylum in the US under the MPP. This implied making their living conditions precarious in an extended and indefinite manner to focus on a petition they were not sure they would obtain. Faced with the emotional and material exhaustion generated, they gave up the application and resumed the refuge petition in Mexico again. They considered that it was a way that would allow them to get out of the strandedness condition, to rebuild their life projects with greater certainty in Mexico. In addition to the labor and educational opportunities they found at the Mexican border to develop feasible life projects. After being a victim of torture and extreme violence, Joy fled Cameroon, leaving behind her 4 children. Arriving at Mexico's southern border, she obtained, without applying for it, permanent residency as a stateless person. She now lives in Tijuana and faces a dilemma. Either she must turn to her legal status in Mexico to start the family reunification process and see her children relatively soon, even though she knows that Tijuana is not a safe place for them, or she must start the asylum process in the US, knowing that it will be a long time before she sees her children again. Faced with the dilemma, she builds parallel projects, which require investing financial and emotional resources that keep her exhausted for an indeterminate period. Often migrants face various challenges specific to the border region and their migratory status, Some continue to face multiple concerns due to the conditions their families are living in their places of origin, or need to care for family members traveling with them. In both circumstances, migrants encounter limitations in caring for family needs, which detriment their well-being. These experiences shed light on the communitarian and relational sense of well-being. Marcos flees El Salvador with his wife, 2 daughters, and mother after receiving death threats. Since leaving his place of origin, he assumes responsibility for taking care of his family's needs. For him, the asylum process under the MPP implied the confrontation of several unforeseen conditions, such as seeking help for his mother's health problems, his daughter's education, having access to a safe place to live, and providing emotional support for his family in the face of a long and uncertain process. Even though Mario is going through emotional difficulties, he tries to encourage his family, hiding his vulnerability to the situation. To confront his emotional condition, he resorts to religious practices, both to ask God's intercession on obtaining asylum and to maintain hope, as well as to recognize from his relationship with the sacred the emotional difficulties he's going through. After being subjected to violence by an extremist group, Seydou had to flee Burkina Faso, leaving his mother, his pregnant wife, and his son under the protection of his uncle. After a long and challenging journey, he reached Mexico, where he was granted refugee status and found a job to provide for his basic needs. A few months after living in Tijuana, his uncle was killed in a massacre in his place of origin. His family became helpless. So Seydou went to the Mexican Commission for Refugee Aid to request the refugee status for his family and get them out of Burkina as a matter of urgency. However, this commission, what she got was only confusing information and the warning. It is a procedure that takes between 7 months and a year. Seydou thought about the situation of danger and extreme defenselessness of his family and answered, I don't know if in 7 months I will still have a family to bring. He's currently experiencing a severe depressive crisis. The condition of strandedness increases the needs they must meet. Therefore, the limitations they face to achieve social, cultural, and economic integration in the places of strandedness have implications for their well-being. In some cases, they experience the need to develop parallel migration projects, which implies the investment of significant financial and emotional resources with no certainty as to which, if any, of these projects will become real. Although he is only 18 years old, Aziz has already made the undocumented journey from Ghana, his birthplace, to this border twice. The first time he was deported while still a minor. Now, while he waits for the opportunity to apply for asylum, he works in the parking lot of a supermarket in Tijuana, where he spends his time making plans while working. One day, he dreams of bringing a wife from Ghana that his family would choose for him. Another day, he thinks about revalidating his school diplomas to continue studying in Tijuana and attend university in the future. But he also plans to enlist in the Mexican army to secure a livelihood. And at the same time, he longs for all these dreams, for which he invests energy and emotions. They could be suspended if he is authorized to cross the border to seek asylum in the U.S. Carvel strives to learn Spanish, obtain decent housing, and improve his job to receive his family in better conditions. He went through the lengthy and costly reunification family process under the National Immigration Institute as an stateless person. At the same time, Carvel invested time and money to apply for asylum in the U.S. Finally, the timing works out, and he manages to combine both projects. Once his family arrives in Tijuana, he gets the support of a sponsor to cross the border, so they all cross together. Then they begin a new and long waiting process in the U.S. with the illusion of being granted asylum.
2 minutes.
As a conclusion remarks, we would like to share some ideas. For people who have fled violence, a central aspect of well-being is inhabiting spaces where they can safeguard their lives. However, preserving life in conditions of strandedness continue to undermine well-being. Addressing strandedness, spatial and temporal conditions, allow us to identify asylum seekers' needs to experience well-being. Spatial conditions are not limited to the material resources available, but to the subjective meanings that the space acquires for migrants' populations as places from which it is possible to sustain a life project aligned with their well-being perspective. The indeterminacy of strandedness, temporality, exacerbates the uncertainty of concluding the migration project, undermining well-being. We identify three aspects relevant for migrants' well-being while being stranded: to maintain or redefine migration projects that will allow them to build affordable and desirable life projects, to keep or recover the family unit and integrity, and to gain access to social, cultural, and economic resources in the context of the strandedness, allowing them to experience integration amidst indeterminate uncertainty. Well-being for asylum seekers in conditions of strandedness is not limited to meeting their basic needs in the present. However, to the possibilities they have in the world to develop dignified life projects in context where they could be attainable. While the tension between putting the life in waiting and the life that continues drawing on is not solved, the conditions for a dignified life project are not granted. Thank you for listening.
Questions? Okay,
it's really exciting work, Olga. So I guess I would be interested in your thoughts on what Derrick Silove presented earlier about detention centers and the harms of conditions there compared again to this, forever waiting and never being able to integrate and putting your resources for the survival in such a dangerous situation on the border when migrants get stuck there. So, how do you think about these two options and what are the implications?
Well, we have shown with these stories as well, and this is something that we continue to explore with the people there, that of course there is all these hard situations they are dealing with, but also the way they manage, they find ways to cope with it amidst this very hard situation. So when we talk about the strandedness, it's just to highlight that they are sometimes waiting, but they don't know what they are waiting for. So they are like having different directions they could go, but they don't have the certainty that these directions are really viable for them. So it's a condition where they are struggling every day, trying to cope with that and finding ways to endure these situations. So I think that that's something, these tensions are present always in their daily life, and it has to do with these different situations they are dealing with and low possibilities of dealing with them and the constrictions. So it's a very dynamic situation that, as we said, like it undermines well-being in that sense. They can have stability at some point, but then again, instability. So it's a very fluent situation.
Can I say something? I just want to say that I totally understand what you're saying. I'm counseling someone from Jordan. Actually, he's Palestinian, and his family are stuck in Jordan, and he's here by himself. He has 4 kids, 3 girls, 1 boy, and his wife. So he's very worried about them. He did seek asylum, and then he doesn't know what's going to happen, exactly what you're saying. And he's, I totally fear everything that you're saying because I'm counseling him, and he's having a really hard time. He's depressed. He wants his family. He's worried about them. And he's like, his wife works, but it's not even that. It's an emotional, psychological being away from the family, missing on his children growing up. He doesn't know his children. What's camera and phone? That's nothing, right? Like he talks to them with a camera and a phone. So I totally understand everything that you're saying. And it's very difficult for him. I try to support him. I'm his psychologist, but it's devastating. I totally understand what you're saying because I see how he is, and like you said, there's no hope. there's no way out, just no hope. He doesn't know what to do. And if he goes back, he's going to go to jail because of, the Palestinian Authority working with Israel and all the stuff. So he's going to go to jail just because he's fighting for his country and all the stuff. The political situation over there. So he cannot go back because he'll go to jail, and he cannot leave his family, young kids and a wife. That's probably a similar situation to what you're talking about. So thank you. It's a very important point that you're touching on.
Thank you for this comment.
Thank you very much for that. I was really struck by the young person who has so many different options: marriage with somebody who gets chosen for him, learning Spanish and going to school and university, crossing the border to see his father. So that is like three totally different kind of strategies all going on at the same time in his mind. But I haven't thought about this for a long time, but I remember when I was interviewing Afghan families about mental health, especially young adolescents, they were saying to me, and I think it's interesting because the next presentation is on trauma, that mental health is not determined by the past, but by the future. Because it's the narrative and the meaning making and the articulation of coherence between the past, the present, and the future. And so if the future has no coherence, you have very poor mental health. Mm-hmm. So I think you just reminded me of that. Thank you. In the sense that, it's not so much, we're very often thinking about the past and the present as a determinant of health, but we very rarely think about the future as a determinant for mental health.
Yeah, thank you. This is an interesting comment because we found that they are carrying all the issues they live in their home countries as well, but at the same time, they left with a hope to find a better place, to find a stability, to start again their life projects. And yes, when this future is not very clear, is uncertain, and it's probably not feasible from their own desires or what they want in their life, this is what it becomes like for them, very shocking and detriments their conditions, of course.
I just want to add to what you're saying. There's no hope that they will get an asylum. It's just maybe. So they know it's maybe. It's not for sure they will live in the U.S., correct?
Yes, and that's why some of them try to find other strategies, like crossing undocumented and not requesting asylum. They are just going to, or change the project and stay in Mexico, even if they are dealing with other precarities, but at least they have for sure something. So it's very clear how they are like handling and trying to struggle with that.
I think that it's very interesting that there's a time and a space dimension to this. The idea of being stranded in space and suspended in time. Mm-hmm. Yet it doesn't mean that they're frozen. Mm-hmm. And this is why I really like the idea of project, the way you're thinking of things in terms of having a project. Because and that they have multiple, that they're thinking constantly and improvising, right? Mm-hmm. Improvising and strategizing. So in that way, having a project goes around or sidesteps the idea even of agency, and it sidesteps even the idea of hope. Because you can have a project with very little hope, right? But you're still trying to figure things out. So I do very much like this idea of thinking in terms of projects, even beyond the idea of agency or hope.
Yeah. And how the migration project is quietly intertwined with the life project as well. So it's like seeing these dimensions of their experience that are overlapped as well. Thank you for this comment.
Can I ask a quick question? Do you know, I know a family in Mexico and they're trying to get in the US and seeking asylum. That's possible. They come in the border or they won't let them in the border. I don't know how that goes. Do you know?
Yes, well, it has changed a lot over the time.
Uh-huh.
A lot of people was rejected, and before it seems that in the Tijuana San Isidro border there was no way to request asylum, but then the process have changed in 2016 and 2017. There was a big amount of people requesting asylum, so the Mexican National Immigration Institute, they started like with a notebook with a waiting list just to start a petition. So they were not starting the petition yet, but there was a list and they were called by numbers. Then that changed, and now the procedure is quite different. They should do this through an organization and ask for a parole, and it has changed a lot.
It's a Mexican organization and they ask for parole, you're saying?
Yes, and a civil society organization based there.
Oh, okay.
So it has changing a lot.
Yes. Thank you, Olga.
Thank you.
All right. Our next speaker is Dr. Hans Reiling, who is a psychotherapist in private practice and an assistant professor at the Chicago School of Professional Psychology campus here in San Diego. He has also provided mental health services to asylum seekers through Survivors of Torture International. Hans's talk today is called Trauma Loops, U.S. Immigration, Detention, and Reverse Causality in PTSD.
Probably I should write something like that text. Okay. No, I can call, but I don't know if I have to add the number before.
Right, thank you. It's been a long day with a lot of rich information, and so I'll try to go slow here and talk about immigration detention, and particularly this place here, Otay Mesa Detention Center, where I conducted more than 30 forensic mental health evaluations before the pandemic. And just want to first of all locate this place also in urban space, 25 miles southeast at the outskirts of San Diego. And it's a peculiar place where not many San Diegans would go. It's grouped together with the state prison and juvenile detention facility. And it's actually only 2 miles from the US-Mexican border. So Otay Mesa Detention Center was established in 2015 and is operated by CoreCivic, a for-profit company that was formerly called the Corrections Corporation of America. And this company actually started the first for-profit private prison in the United States in the 1980s, and has since then expanded its reach also into the immigration system. And the facility has contracts with ICE and the US Marshal Service, and most of the detainees, though, are asylum seekers. So in 2020, there was an average daily population of 730 detainees with a maximum capacity of 1,142 in the facility. And I'm also, in a minute, I'm going to say a little bit more about how this changed in the wake of COVID-19. Average stay has been like about 3 months, but I have also worked with detainees who had to stay there for much longer than a year. And this practice of immigration detention is relatively new historically, and it started in the 1990s, and especially after the Illegal Immigration Reform and Immigrant Responsibility Act was passed during the Bill Clinton administration. And in that act that is now part of Title VIII, there's it specifically stated that people who wait for their court case, they shall be detained. And we know it's not always applied, but it is often for so-called arriving aliens who come to the border. At least it was that was the case pre-pandemic. And so, and another impact was the Homeland Security Act. And I would say, like, immigration detention must really be seen in the larger context of the US prison industrial complex and the criminalization of immigrants. And if you look at the numbers since the 90s, the number of detained asylum seekers constantly, or immigrants, most of them are asylum seekers, went up to 50,000, I think, even like in 2019, up from 5,000 or 6,000 in 1994. And since the pandemic started, the numbers went down. These are the figures from Otay Mesa Detention Center. At the beginning of last year, there were 700 detainees, went down, and right now, like, there are even less people in there. One would think it's a good thing, but it's actually not, because, like, during the past year, like, more than 1 million people have been denied the right to asylum when coming to the border under Title 42. So what's the significance of these forensic mental health evaluations? So asylum seekers have very slim chances of actually succeeding at court. About like 90% of applicants who don't have an attorney are denied. And this means that it's really important to have legal counsel, and attorneys always seek for evidence in the face of, often not having much at their hand. So a mental health evaluation has become actually a sort of a biopolitical capital that can be used to get asylum. And although the right to asylum does not depend on a mental health diagnosis, such diagnosis enhances the chances of success at immigration court. So aid organizations and their attorneys recruit mental health clinicians to evaluate their clients in the hope of establishing credibility. And immigration judges use these evaluations to determine the credibility of the asylum seeker's narrative. Doesn't mean that if somebody has an evaluation and is diagnosed with PTSD also gets asylum, but the chances are much higher from everything that I have heard from attorneys that I've worked with. So now I conducted 32 of these evaluations at Otay Mesa. And usually an evaluation includes a semi-structured interview, and people go through the Hopkins symptom checklist and the PTSD checklist for DSM-5. And all of the people that have been referred to me, almost all of them, like 31 out of 32, met DSM-5 diagnosis, a diagnosis for PTSD, and almost all of them also for major depressive disorder and generalized anxiety disorder. And here I have a picture of DSM-5, just also to point out that this is a cultural artifact, and which has like certain ideas around how PTSD works. And the main idea is to establish a link between a past event and current mental health symptoms. And I'm going to get to that in a moment. So there are the different criteria: the exposure to the traumatic event, intrusion, avoidance, alterations in cognition and mood, arousal and reactivity. Those are the main ones. And usually they can be seen in this linear sort of model. So this model is based on an idea that memory could basically be stored in human beings, like just like on a disk or a hard drive, and it's just in there. And from there later on, these re-experiencing symptoms and flashbacks come up, and then also the rest of the symptoms. So current circumstances or events are blended out in favor of a past etiological event. And a lot of mental health clinicians know that this is not really how it works, because memory is more complicated. And I see it as a sort of a looping where the current circumstances can actually provoke these re-experiencing symptoms and lead to new traumatic experiences depending on what's going on in the environment. And in the context of detention, traumatic memories that might have had mild effects on a person or no effects at all might be triggered during detention. And a lot of the detainees I talked to, they tried to do something about that. And they wanted to basically not remember and not have these negative intrusive thoughts. So what they did was they signed up for so-called volunteer work with Core Civic. And I'm going to present a couple of quotes now. So I have here a transgender woman from Honduras. And she said, "I wasn't able to feel happy since I came here. I like to dance and I like to listen to music. I like to socialize, but I don't feel like doing it here. When I sing, it makes me feel better and I forget about the past. But then the guards come and tell me to stop. I don't understand why. I always like to sing, it relaxes me, but here I can't. I can't even get a hug from my trans friend because it's prohibited. That makes me sad. When I go out, I'm always alone. I don't communicate because I'm afraid of man. And you see here, like some of the experiences she had in her home country. And sometimes I clean the floor, she said. I wanted to be occupied with something. I wanted to do something during the day, and I thought if I had work, I could distract myself. But they put me on night shift. I cleaned the floor from 11 p.m. to 12 a.m. and I'd sleep longer if I didn't depend on the schedule. When I wasn't working, I would go to bed at 10. I would sleep at 11 and get up at 5 for breakfast. I started 2 weeks ago with the work, and since then, I'm not having breakfast anymore. I feel like I'm losing weight. For 1 week, I haven't been eating breakfast. This is one example of an experience, and another one here from a 35-year-old cisgender man from Anglophone Cameroon, and he had a bachelor's degree in his country, and he said, I signed up to clean the bathroom 5 times a week to keep myself busy and not think about Cameroon. The main reason is to keep myself from thinking about the past. When I started working, I was not thinking of money because it's not money for me in comparison to what I made as an accountant in Cameroon. I work 5 days a week and they give me $5, but the check is actually $4. We don't look at our hours because we just want to keep ourselves busy. A lot of people who do that job think like me. My salary was more than $1,000 as a consultant, and I was fine. I wanted to build my own home. But here, cleaning is a good thing because it keeps me busy. You're not thinking negatively only if the toilets are not flushing and there's a big mess. Sometimes I get very disturbed when people are not cleaning after themselves. When I see the toilet that's not flushing and it's full of feces, it reminds me of the torture back in my country. And this was a man who was put into a bucket of feces and urine to simulate drowning. So I have more of these stories, but basically they speak to the conditions at Otay Mesa Detention Center and the sort of labor exploitation that takes place there. This other vignette would be about a man who felt he had to earn some money through this program that they provided in order to buy food from the commissary, because he said you can't really eat that food. The food is pretty bad. So he had to work to get some noodles from the prison shop. So these are the type of conditions. And
2 minutes, Hans.
Okay. And recently, even ICE found violations of its standards in the facility. They didn't point out the labor exploitation and the problems with access to medical care, but they did point out problems with the facility not enforcing COVID-19 guidelines and some other problems. Now, interestingly, since the pandemic, the numbers dropped, but ICE has a contract with CoreCivic and guarantees to pay for at least 750 beds. Now, the detainee population went down, and you see here in April 2020, an average cost, daily cost was $186. In March 2021, it was $339. Because, at that time, there were I think about 400 detainees. And I have some more information here about the COVID response in the detention center. It was last year when the first COVID-19 death in U.S. immigration detention occurred. And the person, the man, 58-year-old Carlos Mejia, he actually fled El Salvador in the 80s, and he had been in the United States for a while, was detained, and the beginning of the pandemic, he was protesting against the CoreCivic's COVID response. He went on hunger strike because they didn't provide testing. There were problems with actually isolating people who had symptoms. They wanted people to sign releases in order to get masks. So he participated in a hunger strike. He was put in segregation, which means solitary confinement. And then later found he had COVID-19, and then he was released and taken to Paradise Valley Hospital, where he eventually died on a ventilator. So this is my alarm at my 20 minutes. Thank you for listening, and hope you have questions for me. I didn't get to the alternatives to detention, but please.
Hi, thank you very much. Could you talk to us about alternatives to detention?
And also a little bit more about the COVID-19. There you go. We gave you the opening to say the rest of what you wanted to say.
I mean, there's some stats here about COVID-19. And, this is a picture also from, I'm going to do one after the other. That's a picture that was taken by a guard through the surveillance camera, and in February 2021. And you see here that obviously masks were not enforced, social distancing was not enforced. And eventually ICE found out, and they're now finding the facility for it. So, and there's more to say about that, but when you think about alternatives to detention, there was this really interesting study in the 1990s when the Vera Institute of Justice demonstrated that people who are just able to be in a community environment and participate in this appearance assistance program, they were actually more likely to appear at court than the people on parole or on bail. So most of the people, they actually showed up. So they said, what's the point to detain all these asylum seekers? And obviously the government didn't really listen because the number of detainees went up. But the idea of alternatives to detention was taken up. And it was put in the hands of another private company, different private companies. One of the biggest ones is the Geo Group. with its behavioral interventions program that is responsible for the surveillance and monitoring of people who wait for their trial through all these different methods with the smart link. That's like through the phone and taking the photos and the GPS monitoring and so forth. And the surveillance is actually increasing. So in the fiscal year of 2020, there was an allocated 149 million for this type of surveillance. Now for 21, it's a 440 million. So you see, like, there's heavy investment into these technologies. And just one more thing I wanted to share here in that regard is the experience of a man who had the ankle monitor bracelet on his foot for about 2 years, and it was malfunctioning, and it was going off at night over a period of time, several times. And each time he could feel the ankle monitor to go off, he would have traumatic re-experiencing symptoms, and it was horrible for this man. He got some treatment, psychiatric treatment, and he was part of a man's group with Survivors of Torture International. But it was a situation. We couldn't do much for him because he would go to ISAP, that's a program, and report that what's going on, but nobody believed it. And he said, they're just not listening to you. And I had this, I heard the same thing from other survivors. And if you look at it, I mean, on average, there's one case manager for 125 participants in the program. So I'm going to stop here. And, actually, I had some concluding thoughts also. So, but I can leave that open, or if you want to hear them, I can add them.
Well, do we have any questions other than asking you to tell us your concluding thoughts?
I do have one question for you. Thank you so much for your presentation and the work that you're doing. The Tacit Project has been collecting a lot of data on provider well-being, and one of the themes that has come up is a stronger connection between legal services and psychological services due to psychological evaluations being such a big part of the asylum process. I'm wondering if you agree, and if you could speak about how we can improve this process on top of, dismantling MPP and no longer requiring detention.
Yeah, I think it's key to collaborate with attorneys, and actually Survivors of Torture International has a yearly provider meeting where immigration attorneys, mental health clinicians, and medical doctors come together and talk about the latest developments. And I mean, it's key for us also to know what's going on the legal side, what kind of information they need. So yeah, it's a good point. And I think it's really important.
There's a comment.
So yeah, I just want to say, more research is needed to understand how present moment embodiment determines the course of post-traumatic stress after torture in the US immigration system. And the post-traumatic is really often a misnomer for what's going on with the people in the system.
I just have a final comment here from another panelist, Kristen Yaris, who says the violence of these forms of body restraint like ankle monitors is important to address. the degrees of carceral care and punishment, surveillance from total control inside the detention facilities to these remote forms of surveillance by app or foot monitor are so important to understand the trauma loops you are describing. And she thanks you for the presentation.
Thank you for the comment.
Can I add one thing, please? Can I add one thing?
Okay, last comment.
I had a client who had an ankle monitor. He's from Jordan, and he used to wear pants, make sure it's covered, because he said, this is very embarrassing, shameful. I look like a criminal. I did something wrong. I'm not a criminal, all this stuff. And he comes from a good family in Jordan. And he was like, this is so traumatizing for me. He always had a hard time about it. And he was talking to me about it. And he didn't know if he was going to say or not. But the ankle monitor, I agree with you, was devastating for him.
And we have patients, like, they're terrified to just go to the office and getting that ankle monitor. They think they're afraid of getting it. And yeah, so
They think they're criminals, right?
Thank you.
Our final presenter is Dr. Tala Al-Russon, who is an assistant professor in the School of Public Health here at UC San Diego. She is also worked as a volunteer physician with Doctors Without Borders and with the Syrian American Medical Society. She conducts work to improve the health of refugees from the Middle East and Afghanistan. And her title is Refugees on the Move, Health Along the Migratory Route Between Syria and California. Tala.
Being a refugee is much more than a political status. It is the most pervasive kind of cruelty that can be exercised against a human being. You are forcibly robbing this human being of all aspects that would make human life not just tolerable, but meaningful in many ways.
The more immune you are to people's suffering, that's very, very dangerous. It's critical for us to maintain this humanity.
الان 60 روزه با پسرم همینطوری داریم میچرخیم، ولی هیچ کس نیستش که بگه یه راهی رو بخواد به ما نشون بده. کجا برم زندگیمو شروع کنم؟
If children grow up without any hope, without any prospects for the future, without any sense of them being able to make something out of their lives, then they will become very vulnerable to all sorts of exploitation, including radicalization.
ليش انتوا هنا اليوم؟
طشة الفصل المنفذ الوحيد في غزة، في السجن الكبير غزة، مش في غزة، سجن كبير يعني.
The officials came here and told them, look, there's no way you're going to get papers to continue. Either you go voluntarily or we arrest you.
I respect you. I respect the passport, and I respect.
It's going to be a big challenge to recognize that the world is shrinking and people from different religions, different cultures are going to have to learn to live with each other.
I hope you guys have some energy left in you. After the last presentation, I'm hoping to shift gears a little bit to talk about a story of hope, hopefully, in some way moving forward, thinking about this global crisis. So just a reminder, since some new people are joining in from online and here with us today, I have Moj and Benan here, who are my
research assistants, refugees from Iraq and from Syria, perfect rock stars who have been working with me for the past 3 years to start some initiatives here in San Diego. So just a reminder, we have never seen these numbers before in the world, right, of refugees and people who are forcibly displaced. We are at 82.4 million people who are displaced, and of those, about 27 million are believed to be refugees. There are 4 million people who are stateless, right? Just living completely on the margins of society. Now, 2/3 of the world's refugees, all the world's refugees, come from 5 countries. Those are Syria, Venezuela, Afghanistan, South Sudan, and Myanmar. We know that there are raising inequalities, especially with the pandemic now. We're sitting in a state here in California where a few people are controlling the majority of the global wealth, right? The entire wealth of the world. We know that the pandemic has increased their wealth while also has increased a lot of suffering for people in displacement. We know also that climate change is real, and we feel it here in the United States, and we feel it also in different parts of the world, especially in the Middle East where I come from, where there's a huge drought problem and extreme weathers. Raising conflict all over the world, so more and more people will be displaced. So these numbers are expected to keep growing. And this is just to map out the world's refugee population. So the major producers of the world's refugees, Syria, Afghanistan, Venezuela, Myanmar, Somalia, South Sudan. However, most of the global refugee burden is borne by the global South, countries like where I come from, Jordan, that are limited in resources themselves. So let's keep that in mind, that most of these refugees live in parts of the world that are struggling themselves. This is also a reminder to all of us and has been discussed before in other talks, but this is the socio-ecological model of health. That's how we think of health. It's not just, your age, sex, hereditary factors, it's so many other things. And migration cuts across all of these layers. So really migration is a social determinant of health. And in my opinion, it is completely understudied and not looked at as a real determinant of health. It's also important to say that when we research refugees, we should think of all of these, the place of origin, what happened to them before they took their journey, what happened during travel and transit, their place of destination, and whether they will return or not. So keeping these kind of cross-cutting aspects also is very important in conducting research with refugees. So the title of my talk is really thinking about migration or displacement as a dynamic process. So what I'm hoping to do, and what we've seen from other presenters, that a lot of the refugees that stop in Jordan, a country so far from here, end up here in San Diego. So our research should somehow compare and start thinking of it as a dynamic process, right, along the migratory route. So if we think of refugee health research, including all of these aspects, I think we can produce better research. This is a picture of Damascus in 2009. This is where we used to go for dinners and lunches, beautiful food. So Damascus is believed to be the oldest continuously inhabited city in the world. That dates back to 11,000 years. It was beautiful. In 2011, these are the pictures we're seeing from Damascus. I forget a lot, and I'm only 41, so why am I so forgetful? So I really started looking at the literature, seeing whether displacement and trauma related to displacement increases the risk of dementia. There was almost nothing at all in the literature. So I felt as a healthcare provider, I am not able to give her the answers she seeks. And that's why I started shifting my career more towards research and thinking, how could we as epidemiologists, as healthcare researchers, help these populations through science? So again, thinking of migration as a dynamic process and these mobile populations moving across the countries. So we have here Morgan, who's going back and getting some stuff from refugee families back there. And when she comes back, she does the same thing. Also thinking about health the same way. These people are mobile populations. I have almost not encountered a single refugee who didn't want to return back to their country. They almost all say, we wish we could return back to Syria. We wish we could return back to Iraq. So hoping that more comparative studies between both locations could tell us something about the health of these mobile populations. So we have some research in Jordan that is looking at health needs of older Syrian refugees in camps and outside camps. So they're very different populations. Those who live in refugee camps are usually poorer. Those who cannot sustain living outside, they're usually sicker. They don't have access to employment, right? And they don't have a perfect access for education. There are some schools, primary, elementary schools, but those who live in the community have different needs as well. They don't have the access to healthcare the same way it is in refugee camps where things are more contained, where NGOs kind of offer more help and it's easier to access those NGOs. So very different needs for refugees in camps versus outside camps. I am also trying to answer that question, whether mental health trauma impacts cognition over time. This is a question that hasn't been researched. And I think in the context of the Syrian crisis, this would be a very interesting question to look at since, the type of trauma that this population has endured is severe and it's sudden and it happened recently. So we are able to follow these people over time. Finally, here in San Diego, I'm hoping to look at implementation science. So taking interventions to the community of refugees and seeing whether it works or not. So this is a little bit different than the epidemiological cohort study that is going on in Jordan, but also experimenting with how a population of refugees here would accept a culturally sensitive implementation project, given that a lot of my team are refugees themselves and are embedded in the society here. Finally, we're also looking at COVID-19 impact on refugees, and I'll share with you more of this particular study's results. So I've had some early research with similar populations before, the population of the prisoners population. I did research of mobile home trailers. I did research for the homeless population. And I'm always thinking about institutionalization, right? So I'm thinking of detainment, containment. How does that impact brain health? How does that impact different health outcomes? So there are a lot of similarities between these different populations. And I just wanted to point out that, a lot of us, seeking grant funding, et cetera, I get from grant reviewers, but the refugee population, how many are there out there? So what I want to say is that a lot of the learnings that could happen from this population could be applied to other similar populations. So I'm focusing most of my research, how does displacement impact chronic disease management over time? We've learned a lot from orphanages about the performance of children who have lived most of their life in orphanages and how that impacts cognition over time. So I'm hoping to do the same thing in the Zaatari refugee camp. The Zaatari refugee camp is truly a village on its own. So you can't see the end of it when you walk inside. And there's a lot of innovation there, restaurants going on, wedding venues, life goes on, even if it's a refugee camp. However, now that we're conducting a lot of our interviews, like I talked to Catherine the other day, the words, there are some certain words like feeling like I'm in prison, feeling like I'm pressured, feeling I lack freedom, although I'm able to walk around. So, a lot of the research, again, is trying to see what are the aspects of encampment or institutionalization that impacts one's perception of health, and thus their health behaviors, and thus their adoption of different health interventions, right? Because it's highly, highly interrelated. So this is a map of Jordan, and many of you might not know this, but Jordan is the second largest refugee resettlement country per capita in the world. So 1 in 3 people in Jordan is a refugee. Historically, it was called the East Bank, and Israel-Palestine was the West Bank. So Jordan has been formed as a country to receive a lot of refugees, historically from Palestine, Iraq, and as you can see, all the neighboring countries of Jordan are countries suffering from conflict in a way or another. And this has been mentioned also in some of the talks before, but about 85% of Syrian refugees live outside camps. So they speak the similar dialects to Jordanians. They're embedded in the community, while 15% live in refugee camps. This is our publication with the WHO East Mediterranean Journal, really characterizing the different health needs of refugees, those who live in camps versus those who live outside camps. This was the first paper to really start thinking about, those who live in camps, what kind of needs would they have compared to those who live outside camps? Many of them are mobile too, right? So they leave during the day to work outside, then they come back to the camp. They spend their weekends in the refugee camp. So we did a mixed method study and really thought about the health priorities from the perspective of refugees for those inside camps versus outside camps. And this is Dr. Bernard Lamb at Harvard, who is my mentor and who supported this work. And I like to always remember his quote here: "We physicians who shepherd human life from birth to death have a moral imperative to resist with all our being the drift toward the brink. The threatened inhabitants on this fragile planet must speak out for those yet unborn, for posterity has no lobby with politicians." These are some images from our research. As you can tell, there's a males group and females group, so we kind of interview both. This is an aerial image of the Zaatari refugee camp in Jordan.
Tala, step closer to the microphone.
Oh. So now switching, taking you back to San Diego here. Many of you might not know this also, but San Diego is a large refugee resettlement hub, one of the largest in the country. There was a US Immigration Policy Center here that produced this report showing that 1/3 of San Diego's essential workers were immigrants, and that the fastest growing foreign-born populations here are from Syria, Kenya, Sudan, Iraq, and Nigeria. We continue to be resettling the largest number of Syrians in the country here in San Diego. And now we're expected to resettle one of the largest amount of Afghanis too.
2 minutes, Tala.
Okay. Just the story of what happens to refugees when they come here. So they arrive at the airport here in San Diego. The HHS, the Office of Refugee Coordination, whom you've heard from during this conference, takes care of them for 30 to 90 days only, basically screening them, connecting them to different services. And then those refugees are sent to certain enclaves here in San Diego, El Cajon, City Heights, where 23 to 30% of all residents in those areas live below the poverty line. The majority of refugees who live here are East African or Middle Eastern. However, the social fabric in San Diego is very unique in that, as you heard also during this conference from the San Diego Refugee Coalition, they formed a group of ethnic community-based organizations that came together and thought, okay, now these refugees are left on their own to navigate a whole country, a whole system. What can we as NGOs, ECBOs, what can we do? And then the Family Healthcare Center of San Diego is the main health providers. It's not us at UC Health here. It's these federally qualified healthcare centers. There's no tertiary care, so it's primary care. And we are now researching a lot of the issues that they're facing in terms of working with refugees. So a lot of the cultural insensitivity, language barriers that come up, transportation barriers, those are all now we're trying to characterize in our research. Another question that came up, CVD, cardiovascular disease, how does it impact refugees? Or are refugees at higher risk for developing cardiovascular disease just solely because of being refugee? That's a question that has not been answered. So we recently conducted this meta-analysis to isolate the effect of displacement on cardiovascular disease and different risk factors. And we saw that yes, being a refugee only after you adjust for so many other things does impact your risk of CVD. So you are at a higher risk of developing cardiovascular disease if you are a refugee. Now, the main project that we're conducting here in San Diego that Benin and Mauj are part of, we are teaching refugees how to measure their blood pressure at home and keep track of their measurements in a diary. And we're seeing whether they like doing this or not. So basically taking healthcare to refugees' homes, since a lot of the barriers that they deal with have to do with language, transportation, not feeling welcome at the healthcare setting, not having somebody to navigate care with. So we're basically taking the technology out there by having them wear connected blood pressure monitors so that their providers can see their readings and make decisions related to healthcare, to medications based on these readings. This is a study looking at the impact of COVID-19 on the community. So in partnership with the Partnership for Advancement of New Americans, PANA, which is one of the ECBOs here, we conducted the survey by phone just to kind of have an understanding of what's going on with the pandemic here with the Refugee Society. So we surveyed 191 African refugees and about 258 Middle Eastern refugees. As you can see from this demographics table, most of these refugees don't own their home. They're renting their homes, okay? Most of them are living in economic hardship. Many of them are unemployed. Most of them don't speak English at home. Most of them have children. Okay, this is just to tell you, we asked them if they're bothered by emotional problems, and 47% of them said yes. We also looked at aspects of COVID-19 stress, community stress that are really correlated with that. And for the African refugee community, with the families are unable to get cash for daily expenses, they can't have enough food, and their children are unable to continue their studies at home. For Middle Eastern refugees, they are reporting more violence in the household because of the pandemic. And they were also reporting that people are becoming more anxious and depressed in their household. Those all correlated with their own mental health. Finally, I just think, leaving on a positive note, I think there is a lot of room for innovation, opportunities. Clinical care, we can do a lot for clinical care. Trauma-informed care, more cultural sensitivity, kind of thinking of a model where community health workers can be embedded and refugee-focused. They can be refugees themselves. Many of the physicians that have been physicians before and are displaced can work as community health workers. Advocacy should be multi-layered, cross-sector, equity, social, political determinants of health, justice, innovation, and team-based care and policies. These are our collaborating organizations and us doing research here. And thank you. Thank you.
Well, I think that you were right. You were ending on a positive note, a note of hope. Placing you last on the agenda, I didn't have that intention because I didn't know what you were going to say, but it's a wonderful serendipity And I think one of the best places to leave us is just to reiterate the last things that you had on your last slide: clinical care, advocacy, equity, justice. If we have those things, and if we encourage those things and promote those things, all of our work will not be in vain. And that includes the energy we've put into the last 2 days. So strong, ringing endorsement of those 4 points.
I have a question. I'm so thrilled to see your science and all the ways in which you are leading. And it just makes me think about, how do we get more people from a refugee experience on the pipeline to being leaders and being, at the table setting the research agenda? And, what are the barriers and facilitators? What can you tell us about that so that we can diversify, who's really in the lead here? Because I think people like you are the future.
Thank you, Teresa. So I have Moj here, who has been a rock star, 2 times refugee herself from Iraq. And she has really helped us shape everything. She has taken on this job with a lot of passion. And she's now applying for residency to become a family medicine resident. And she was looking for research experience. She reached out to us, and Moj has been a rock star and has helped us a lot. So I think, Teresa, being deliberate in who you hire is really key. And I think there are a lot of assets out there and a lot of refugees that are looking for opportunities to be part of this, to shaping their own narrative, shaping the research that's being done with them. So, being deliberate in how you present them on the leadership, not just on collect data or do things, but really, how do you grow so that you become a physician and carry on this experience with you? Or if you stay in the academia and want to continue a career as a refugee, surfing refugee yourself, how do you lead forward? And that's what we're trying to do here. So I want to always emphasize that, please, if you can, put them in leadership positions, they are the best to carry this mantle.
Can I just say a comment? I want to agree with you. You touched on the same point that I was talking about, dignity and giving refugees, a lot of power to do things, and how they feel low self-esteem because of the loss of status. They were doctors or engineers or successful students in Iraq or Syria or other countries. And it's good to give them a chance, and the dignity and how their self-esteem would improve tremendously if given a chance. And they're very hard workers and they could do a lot. I agree with you.
Not just give them a chance, but make them instead of you.
Yes.
Having the humility, the professional humility to really understand
that
nobody understands someone's pain unless they were in that
position. That's true.
Final question. I was just wondering if you're looking at the suffering and memory loss with different populations inside camps, outside camps.
Yeah, so that project that we didn't talk a lot about, that's looking at mental health effect on cognition, we are really looking at exactly that. So we're looking at PTSD, anxiety, different mental health outcomes or exposures, and we're testing cognition using a tablet. So really through MoCA also, which is a battery used to test cognition. So yes, we are looking at that, and that's a huge study. That's a cohort that we're building. One of the things also that is lacking in refugee health is the longitudinal research. Most of the research on refugee health is cross-sectional, meaning you take one snapshot time at what's happening, and then you leave and carry on in another location, another project. So I'm kind of really hoping to continue with the same group over time so that we are able to have a better, cause-effect relationship and be able to comment on a lot of those. Thank you.
I want to add just a brief comment. Thank you so much for your presentation. It's so interesting and valuable. And also to acknowledge, you being involved as refugees in all this process. And I was thinking about some migrants that in the Mexican side, a few of them that are interested on being lawyers just to fight for migrants' rights as well. And I was thinking in your experiences, if the experience of being a refugee was something that transformed your life project, something that you became interested on, being involved on these issues after being refugee, and which were the opportunities. I was thinking about a specific girl in Tijuana that after giving her testimony in different panels was offered a grant to study law in a private university in Tijuana.
Nice.
So it was the result of being like voicing other migrants.
Right.
And I wanted to know like the way you became involved and the opportunities you found.
Right. I don't know, Moj, if you'd like to speak about your own experience and how, your career kind of led you to this work, but I can speak about my own. I'm a daughter of refugees, and there was not a single day on the dinner table that we didn't talk about that, lingering to going back home and how that impacts different things. My dad, his parents were from Syria, and he moved when he was a little child as a political asylum seeker to Jordan. And he would always, he's hypertensive, diabetic, and he doesn't take his medications on time. So I'm like, Dad, you need to keep up with your medications. He's like, life is not worth it, after what's happening to Syria and not being able to go back. So as a physician, I couldn't help but think of, again, the trauma and the baggage that patients carry with them and how that impacts their health decisions. So when I became a physician, I was also morphing very slowly to, again, the struggle of mine trying to answer questions of my dad's situation. Why isn't he taking his medications? Is it really related to what happened to his parents and his ancestors and what he's carrying with him? So yes, personal experience do play a big major role. And it makes you not want to quit. I was, again, in my career, my professional career, I was always pushed to do something else, but I would keep coming back and try to get funding and try to work on refugee health, because I know that there's a huge research gap. Maybe it's not a topic of interest to many donors or etc., but actually there's a huge need to do something in that field. And if done, with minimal efforts, it could have implications to global populations, to millions. So yes, personal experience play a major role. It's just having the right mentorship, the right opportunities at the right time. All of those play a major role.
I just wanted to say, in terms of memory loss, all the clients that I worked with that experienced trauma, they all suffer severe memory loss. So it definitely is a contributor. The abuse and the trauma definitely affects memory, yes.